Hello, this is Dr. John Wallman. We're here with a series of short videos, Reasons for Calm regarding the COVID-19 pandemic. This one is the culmination of many of the other videos in this series and asks the question, is it time for a change in strategy? Current strategies for COVID-19 response have focused on flattening the curve, slowing the rate of spread. This has been done by closing schools, closing businesses, restricting travel, basically shutting a large percentage of the population down from work and play and other activities. Why was slowing the spread important? There were a few primary drivers for this strategy in the beginning. One of the key ones was who is transmitting the disease to who. The virulence was unsure. At this point, it looks like the virulence is going to be comparable to the annual flu. But in the beginning, we didn't know if this disease would kill seniors with underlying conditions, or perhaps it would kill seniors and infants that had impaired immune systems, as the flu tends to attack. Or would this disease kill healthy people? That's the real concern and raises the real danger and why you might want to contain this. Is everybody vulnerable to this? One of the other key drivers, though, for this has been the possibility that we might overwhelm hospital facilities. Both the total number of people in the hospitals and the total number of respirators and other critical care equipment that might be available. So let's look at each of these factors and see if that strategy still holds sway with what we know now about this pandemic. So, one of the key factors is we didn't know who could be killed by this disease. Would it kill only the most debilitated, somewhat ill, or healthy people? Well, now we know that there's 80 to 86% of the population that has COVID-19 with little to no symptoms. And this has been verified by a number of good organizations, the World Health Organization Director General, a number of good articles that have been published in both JAMA and the Lancet. The early data indicated that only seniors with severe underlying conditions were being killed, and this has been borne out now for months. Lots of data from lots of places. So let's look at this a little bit more closely, confirming that idea that it's seniors with underlying conditions that are the high-risk patients. Okay, so first, the 80 to 86% of the population is infected, has no or minor symptoms, no hospitalization, World Health Organization, the CDC, and so on. The mortality by age, if we look at that, now here we're looking at absolute relative ratios and not absolute percentages. Okay, so in the 80 years old or older category, 21.9. And then going down 70 to 79, 8, and then once you get down into the 60s, okay, it's dropped all the way down to 1/7 of the number who die in the 80 plus category. And once you get below 60, it drops down very radically. And as of a couple of weeks ago, nobody had died in the 0 to 9 group. There may be 1 or 2 now, but it's extremely low. So the vast majority of people who are dying from this disease are over 70 years old. And it's not just being over 70, it's being over 70 with underlying conditions. So the ones who are dying have this combination of that age plus these comorbidities. So cardiovascular disease, diabetes, chronic respiratory disease, hypertension, and cancer. And those with no pre-existing conditions is extremely low. So to sum it up, the vast majority of mortalities for COVID-19 are with seniors over 70 years of age with pre-existing conditions. Now that has been known for a while and continues to be reinforced. Okay, but then we have this other question. We could overwhelm hospital capacity. And there's two primary drivers for this. One has to do with testing. Okay. In the beginning, when patients went to hospitals for tests to see if they were infected, they needed to stay at the hospital under quarantine once they showed up until the test results came back. And in the beginning, the test results took 1 to 2 days. So you show up at the door, think you have it, you get the test, you go into quarantine. So everybody who's getting tested now is ending up in quarantine for 1 to 2 days until the results come back. And hospitals very quickly ran out of space. Okay. Then the other big driver for hospital capacity had to do with ventilators. COVID-19 particularly attacks lung tissue. Cough is a primary symptom, getting fluid in the lungs, a type of pneumonia, fluid accumulation. All of these things make it very important to have ventilators available for those who are severely impacted by this. Now, if we look at the current capacity of ventilators in the hospitals across the country, we're looking at 170,000 units available. The American Hospital Association made an estimate early on in this process and estimated that if this spread fairly fast and a large percentage of the population, we would need 960,000 ventilators, quite an increase above our current capacity. So, are these drivers still applicable? Well, let's look at the testing first. So the 1 to 2 day quarantine for everybody who showed up at the hospital and wanted to be tested, that no longer applies. We have had now for the past week drive-through testing coming online, other quick testing procedures at multiple procedures so you don't have to go to the hospital. And now just yesterday we had new FDA approval of a test that takes 45 minutes to get results. How about the ventilators and hospital capacity? Well, again, there's 170,000 ventilators currently in the American hospital repertoire. American Hospital Association was estimating that we might need 960,000 for this particular pandemic. Do we still need this number? The early estimates, are they panning out? And the answer is no. Numbers are coming in, and basically the people who are going to hospitals and have severe dyspnea, difficulty breathing, and need to be put on a ventilator is 6.8 people with those symptoms for every mortality. Okay, so 6.8 people show up in a hospital that need the machines. One of those ends up dying. Okay, we do know the mortality rate very clearly right now. So from there, we can back calculate how many people have dyspnea and need a ventilator. So, but how many people are going to show up at the hospital? That's what we don't know. So let's look at a couple models to predict how severe it might be. Number one, coronavirus attacks the US every year. COVID-19 is a coronavirus. Coronavirus is one of the common colds. It accounts for 10 to 15% of all common cold infections every year. Now, COVID-19 is a little bit different than the typical coronavirus that comes around each year. It migrates genetically just as the flu migrates a bit genetically every year, and every year there's different strains. This year there is a different strain of coronavirus, which has a mortality rate that's a little bit higher, it seems, than typical. Okay, so let's use coronavirus as our model, because there we have some numbers and we can estimate things fairly closely. We can kind of assume that, okay, COVID-19 is not radically different than the annual coronavirus, and so the infection rates may be somewhat close. So let's start there. 0.4% of the US population gets coronavirus every year. Okay, So if we're looking at the US population, 330 million, and we assume that 4% of the 0.4% of the population will get COVID-19. That leaves us with 1,320,000 infected people with COVID-19 by the end of this pandemic. Okay, now just to see if that's a reasonable assumption, currently we have 22,000 people infected in the United States in total. So this would call for a pretty wild ramp up from 22,000 to 1.3 million people infected. Possible? Okay, let's see what happens. Then what we're looking at for the mortality rate of COVID-19 is a 0.1%, give or take a little bit. This is based on some of the other videos in this series that we already went through. If you want to see how this number is arrived at, you can look at the other ones. It could be a little high, it could be a little low, but it's going to be in that ballpark. All right. Then that would mean in the United States, using this model, we can anticipate the number of deaths by the time this is done if the coronavirus infection rate holds true of about 1,320. Now, what we have from the early research that's been done is that for every person who dies, 6.8 of them will need to be on a ventilator for difficulty breathing. So that gives us the number of ventilators needed, which is 8,976 over the course of the pandemic. Now that's from beginning to end. We're already a month or so into this. Things are still very low in the numbers. It will go up and get faster, but 8,976, and we have current capacity of 170,000. That's 18 times what is anticipated that we might need. So things would have to either all be condensed, well, even if they were all condensed totally within a 2-week time period, we still wouldn't come anywhere near the number of people needing ventilators. So using this model, we can see we're very, very adequate with the number of ventilators on hand. Now, let's use a different model, one that has not quite as low an infection rate as the annual coronavirus. So maybe this one is a little bit higher. Let's use the flu infection rate model. In the United States, the annual flu results in about 10% of the population getting the flu. Ranges from as low as 5%, maybe as high as 20%. But the current infection rate in the USA for COVID-19 is 0.0068%. So we are way, way under the 10% model, but let's run with this one and see if it's possible. That would be a massive increase in infection rate. Infection rate is anticipated to go up tremendously as testing comes online, but will it go up that much? That's still a bit of a fast jump, and we're coming into the sunny season where the risk is going to go down, which actually, if you look at the numbers from around the world, you'll notice that the infection rates in the southern hemisphere are quite a bit lower than they are in the northern hemisphere. There's a number of reasons for that, including sunlight and UV killing the virus when it's exposed to sunlight. Also, the vitamin D levels are very high in the southern hemisphere right now for the population, and in the northern population, they're extremely low. They're at their lowest levels. So as we come into springtime and summertime, the infection rate is going to start slowing down just from sunlight exposure. But let's run with this model. 330 million US population, 10% getting the COVID-19 infection, using the annual flu infection rate as the model here. That would lead to 33 million people in the US getting infected. Currently, we're at 22,708. So to go from 22,000 to 33 million, all right, that's quite a jump. It's feasible, but let's run with it. So if 33 million people get the infection, then we're looking at a mortality rate of about 0.1%, give or take a little. Then we can anticipate that 33,000 people would die from the COVID-19 in this year. Multiply that times the number of people who get very severe difficulty breathing and need to be on a ventilator, times 6.8, and we end up with 224,400 ventilators needed over the course of this pandemic. Now, we only have 170,000. So does that mean we're 50,000 ventilators short? Well, that would be the case if everybody showed up at the hospital on one day. We would be short that many. It seems the course of this disease takes about 10 to 14 days, and then people are either discharged or adequate to go back home. So long as all of these people don't show up in the hospital in 2 weeks, then we are in better shape. We're actually maybe in good shape. If we use some of the other countries, peak ventilator demand was spread out over approximately 8-week time period, and we'll have to see if those numbers hold up in other countries. But it looks like even with this relatively high infection rate, we should still have about 3 times the capacity needed for ventilators. So right now, it looks like we're either sitting very, very good for ventilators or maybe adequate, but with some buffer for error, and we might have to do some quick sharing between hospitals. Maybe. Okay, so let's summarize all this. The flatten the curve strategy that we've been currently using, isolating basically the entire population of non-essential activities, school, non-key industries and businesses, and travel, stopping all of that was the good strategy in the beginning because we didn't know the virulence of this disease, who the vulnerable populations were. And now we know. This has been borne out for months. It is seniors with underlying conditions. We also used that strategy because hospital capacity was in question. If this disease ramped up fast and people had to be put into quarantine because of testing, and it took 1 to 2 days for every test, there would not be the capacity, not even close. But that now has changed with the drive-through testing throughout the country and now the newly available FDA-approved 45-minute test. Next, we look at hospital ventilator capacity being inadequate, and that was a primary driver for why we had to stop the spread and shut down the country to a large degree, was because if the vulnerable populations and people who got the severe difficulty breathing got to a hospital, we might not have enough ventilators to handle it. And now when we look at updated projections, it looks like ventilator capacity is at least adequate at a minimum, and possibly extensive overcapacity of ventilators, depending on what the final incidence rates turn out to be. So, if containment and slowing the spread is no longer needed, because the primary drivers for that no longer apply, what strategy will protect the high-risk population? Because that's what it comes down to now, to protect the people who are at high risk of dying. Do we stop life in the country to protect the 1%? Well, that's what we've done in the past. We restrict movement and contain the total population to protect the vulnerable population. But the new strategy now that is more applicable based on the new understanding of the profile of this disease is isolate the high-risk population. Seniors with underlying conditions are the ones that need to be in quarantine, not the entire country. The country does need to be educated on safe procedures for quarantining the high-risk population. In other words, how do you handle food for quarantined seniors? How do you handle bathroom facilities for these seniors? How do you do safe procedures for crossing the quarantine boundary to hand in food, other activities for the day? When do you cross the boundary or not? If we adequately now quarantine the 1% of the population, the rest of the population can return to work, school, and play. So to summarize that, the old strategy, quarantine the 99% to protect the 1%, and the new strategy I am advocating is quarantine the 1%, so 99% can continue with life. Let's look at that just a little bit deeper. This doesn't just apply to how we handle today and the rest of this pandemic season. It's also going to apply to procedures going forward with this disease. There's been a lot of talk about how to do this. Quarantine the country, contain everybody so that the 1% does not get infected. There's also been developing drugs to combat the disease directly. We're looking at now one of the malarial medications as an example of that may have some promise. And we've also been talking about vaccines, vaccinating the entire population, again, primarily to protect the 1%. Is that a good strategy going forward? And if you add up all these things we're talking about, no. Our focus needs to be on the 1% and building their immune systems. A vaccine focused on the high-risk population only. It's not needed for the low-risk population. People have gotten coughs and fevers and so forth for millennia. There's no need to mandate a vaccine for everybody to protect the 1%. Protect the 1%. Testing needs to be oriented towards detecting new outbreaks so we know when to initiate quarantines of the high-risk population. Treatments need to be focused on directly combating COVID-19 in the senior populations with underlying conditions. So drug trials that are undertaken with whatever medications need to be done specifically targeting seniors with underlying conditions. It doesn't help our country to do these therapeutic trials on teenagers and 20 and 40-year-olds who are not going to be severely impacted by this disease. We need to make sure the therapies are tested against those who truly need the therapies. So, bottom line, the old strategy when we didn't know the profile of this disease, quarantine everybody. Quarantine the 99% to protect the 1%. Now that we know this disease profile, the strategy needs to shift to focus our resources where it's needed most. Quarantine the 1%, so 99% can continue with life. Thank you.